Hello, everyone. Welcome to the first episode of Functional Neurosurgery Explained. Today, we're starting with what I believe is the most fundamental question in our field. How do we find 1 millimeter in the brain? This series will focus on concepts behind neuromodulation for movement disorders, pain, and spasticity. We'll talk casually but scientifically. The principles that make functional neurosurgery work. Let's begin. So, why do we care so much about 1 millimeter? Because in functional neurosurgery, 1 millimeter can be the difference between treatment and side effects. Think about it. Our targets, the subthalamic nucleus, the globus pallidus internus. They're small, they're deep, and they're surrounded by structures we absolutely cannot afford to hit. A 1 to 2 millimeter error in STN targeting. You might stimulate the red nucleus, and your patient gets diplopia, for example. Miss the GPI by a millimeter or two. You hit the internal capsule or optic tract. Weakness or visual disturbances. Spinal cord stimulation is generally more forgiving than STN or GPI targeting. But even here, a 1 millimeter lead shift can still lead to suboptimal paresthesia coverage. Precision is the treatment, and everything begins with localization. Before we stimulate anything, before we implant anything, we must answer one question. Where exactly are we in the nervous system? This is the core challenge of functional neurosurgery. It's about knowing, with millimeter precision, where you are. Functional neurosurgery begins with localization, not intervention. So, how do we solve this problem? How do we turn anatomy into something we can navigate? The answer is stereotactic surgery, and it's based on 3 simple steps. Step 1. Fix the head. We need a rigid, stable relationship between the patient and our coordinate system. Step 2. Define a reference system. We cannot use skull landmarks, they're inconsistent. We need something internal, something reliable. Step 3. Convert anatomy into 3D coordinates. Once we have a reference, every point in the brain becomes a measurable coordinate. This framework allows us to navigate the brain as a volume, not just a surface. That's the key difference. Let's start with step 1, fixing the head. To navigate with millimeter accuracy, the head cannot move, not even slightly. This is why we use stereotactic frames, Lixil, CRW, and others. These frames create a stable geometric relationship between the patient's head and our coordinate system. No movement, no drift. Now, what about frameless systems? Yes, they exist. They're useful in some cases. But when it comes to millimetric targeting, deep brain stimulation, thalamotomy, frameless systems depend heavily on registration quality, and they're generally less precise. The principle remains the same. If the head moves, accuracy is lost. Step 2 is defining a reference system. But first, let's talk about what doesn't work. Early neurosurgeons tried using skull landmarks and surface anatomy. It made sense at the time, right? But it failed. Why? Because skull shape varies widely between individuals. The relationship between the skull and the brain is inconsistent. And functional targets are too deep to correlate reliably with external landmarks. So functional neurosurgery needed something else, something internal, something anatomically consistent. And that solution came from the anterior and posterior commissures, A, C, and PC. Why does ACPC work so well? First, it's deep and central, right in the midline of the brain. Second, it's close to our targets, the basal ganglia, the thalamus. These are the structures we are trying to reach. Third, it's relatively consistent between individuals. Not perfectly consistent, but far better than any external landmark. The A, C, and PC, a line, became the reference axis for functional neurosurgery. You have a coordinate system, you have a starting point for targeting. Once A, CPC was established, stereotactic atlases emerged. Atlases answer one question: where is this structure relative to mid-PC line? They're based on population averages, 100 cadaver-based anatomy. And for years, that's all we had. It was a powerful concept, but imperfect. Then MRI changed everything. With MRI, we could see patient-specific anatomy. We could visualize targets directly, no more relying on averages. We could plan safer trajectories, avoid vessels, avoid ventricles. This introduced direct targeting. Instead of saying the STN is usually 12 millimeters lateral to midline, we could say in this patient, the STN is right here. Atlases gave us the conceptual structure, but MRI gave us accuracy. Step 3, converting anatomy into 3D coordinates. Once we have fixed the head and defined the ACPC reference, every point in the brain can be described using coordinates. X is medial to lateral. Y is anterior to posterior. Z is superior to inferior. We also define angles, coronal angle, sagittal angle, to plan the trajectory. What does this mean practically? Targets become points, trajectories become lines, and critically, errors become measurable and predictable. This is the language of functional neurosurgery. This is how we turn anatomy into something we can navigate through with guidance. Let's summarize what we discussed in episode 1. Functional neurosurgery begins with localization. Precision is not optional. 1 millimeter matters. We use 3D stereotaxy to define cranial space. The ACPC line serves as our internal anatomical reference. And while atlases gave us the conceptual framework, MRI gave us something better: patient-specific accuracy. Finding 1 millimeter in the brain is the foundation of successful neuromodulation. What's next? In episode 2, we'll dive deeper into reference frames, what are stories behind them, and how we actually define the target, how we plan the trajectory, and how we quantify accuracy. Thank you for watching. Let's continue our journey next episode.